this conference was attended by 30 global participants, and you can see on the videos we were doing virtually, but in our room we had more people in there. So there was a lot of discussions covering the scenario of gestational diabetes. What protocols do we have? What type of patients should we have? What type of training do we need? That's one area that we have to focus on the second medical mission, because there's a lot of gap there, and compared to what the pregnant woman who is experiencing diabetes during the pregnancy, what type of protocol do they have, and what type of protocol we can train people from Tanzania to be able to learn that. So there's a lot of information coming out of that. So welcome to the QHSC Health Series. We're discussing gestational diabetes today. We have our colleagues from US and here colleagues from UTMC. So we have a scenario we're going to go over it, so just to speak of the time. I'm just going to let the doctors we're discussing today to just introduce yourself quickly so we know who it is, and then Ms. Nancy also introduce herself so we can know expertise of people who are here, and then we can dive in. We do have also the QHSC volunteers here on the audience, and hopefully they have good questions for all the three doctors there. Go ahead, Dr. Msambichaka.
All right, so my name is Dr. Lillian Msambichaka. I am a pediatrician and internal medicine doctor based in Delaware, USA. My practice is mostly inpatient medicine. I take care of patients, pediatric patients from like newborns all the way up to 21. And I'm very excited to share with all of you and learn from all of you during this encounter today.
Thank you. Ms. Nancy?
Yes, my name is Nancy Littner. I am a board certified clinical nurse specialist, advanced practice nurse. I'm board certified in advanced diabetes management, and I'm certified as a diabetes educator. I work on the inpatient side right now in Charlotte, North Carolina, managing the glucomander insulin program, and then teaching adult health, pediatrics, and women's health, women how to take care of themselves, actually all populations how to take care of themselves, teaching them self-management skills. I'm so happy to be here. I'm so happy to learn from all of you, and I hope that I can answer some questions that you have about managing this patient population. My longest term was managing, I was the program coordinator at the University of Cincinnati. I worked with Harriet, and we did the diabetes and pregnancy program together. So, and thank you for having me.
Thank you, Ms. Nancy.
Yes. Here is Dr. Johanna Masonda, the general surgeon here at Diabetic. I'm happy to be among this research. Thank you very much.
Thank you, Dr. Masonda. Dr. Kabibi?
I'm Kabibi, the vascular pediatrician in specialist at the UTMC. I was happy to hear about the Johnson checker. I'm taking care of children from 0 to 15 in all outpatient and inpatient. Thank you.
Thank you, Dr. Kabibi. Some of the OBGYN do have surgery this morning, so unfortunately they might not be here, but we are going to record it and then share the video with them. Dr. Mkony from South Africa, can you say hi? Dr. Mkony?
Thank you, Harriet. Good morning, everyone, and thank you for allowing me to join the nice discussion. Okay, I'm a pediatrician currently doing neonatology training in Cape Town at the University of Cape Town. I'm based at Mowbray Maternity Hospital. It's a maternal and newborn hospital.
Okay,
thank you. Hopefully I'll be coming back in December. Thank
you. Okay, so the scenario, of course, based on gestational diabetes. So we have two parts. So we discussed with the G3P1 who is 38 to 39 weeks, so just average that down. And then who received very scant prenatal care, and then of course she's non-compliant to diet because that's what she was managing her diabetes. So we need to know about the treatment, the things that routine that can be done in US, and Ms. Nancy is going to give us what that you usually do with those patients prenatally. And then we're going to discuss about the complication, maternal part, and then you as a pediatrician, you're going to help us with a newborn, what you see after your, the practice of this mom who's experiencing diabetes, and then what the impact the baby is showing. And then the second part will be we go for G5, P3 with 30 weeks gestation, who is good, has a good history, she just goes and get prenatal care. What is the routine care for if she has diabetes? What are the things that we can do intervention-wise to prepare her so we can have less trauma or get trauma at the delivery and help those babies change the outcome for these babies. And then, of course, everybody will have the chance for the doctors, give us the chance, education, what do you advise for these moms when they're going home and how do you prepare these babies when they start going to the pediatrician? What are the things that we can learn, change from the maternal side to impact or improve the outcome for the pediatric side? So Dr. Msambishaka, I'm going to let you start.
Okay, well, thank you. Dr. Harriet, if you could allow me, I'll just give a little bit of background from, as a pediatrician, what I would be looking for, but then invite Ms. Nancy to actually probably do the treatment part from diabetes education of the mother, because the management of the neonate is very much dependent on what the maternal management is, and that's what influences how I approach an infant born from a diabetic mother. So Ms. Nancy, if I could invite you to talk about how you would approach this patient from diabetes teaching in the outpatient setting, what your recommendations would be in terms of oral agents versus insulin, and now that any other recommendations that you make, and then I can chime in terms of what some of the complications from a patient that has had non-compliance and the impact on the baby from our standpoint. And obviously Dr. Mkony can join in as well from a NICU perspective.
So my understanding is that the patient is 38 to 39 weeks.
Yes. Yes, the first one, yeah.
That's very far along. I don't know how much of an impact we could have because the weight of the baby can, or the blood sugars can double and triple, and that begins at 24 weeks. So I would really want to catch that woman and look at her blood sugars at 24 weeks. At 38 to 39 weeks, I would like to see her blood sugars. I would want to measure her fundus. I mean, how big is this baby? Is this baby going to be able to be delivered vaginally? Because if she hasn't had blood sugar control and diet control, medication control, how big is this baby? We would teach, carb counting. It's kind of late. Do we have an obstetrician there, Harriet? What would he think at 38 to 39 weeks?
Ms. Nancy, can you give us this, let's say you have a 20-weeker or you're finding 15-weeker, comes in, you're identifying they have whether uncontrollable glucose, and then just give us your scenario up to get to the 39 weeks, so then we know if the patient shows up at 39 weeks, they've already missed that part prior, so then we know how much they're missing. And then the idea of that question is because we want to show our colleagues here in Tanzania things that are done for a pregnant woman who is 38 weeks received before they deliver that baby. It just give us the timeline of things that we do over there, and then portfolio the most in the pediatrician side, so then we know what to expect from the baby side.
And is the mother, is she imminent for delivery?
Yeah, so she's in labor now. Yeah, she showed up. The first one is
she's in labor now.
Yes.
Yeah. So the most important thing to be, if she's in labor now, is to make sure that her blood sugar is between 60 and 100. Make sure that her blood sugars are controlled. what kind of medication was she taking before she came to the hospital?
Okay, so Ada, just need to know if it's oral treatment or with insulin. So what are the pros and cons for that?
If she's gestational diabetes, normally we don't have to hang an insulin drip if her blood sugars are controlled. Usually the labor, because of the energy and expenditure of labor, a lot of times the gestational patients do not require insulin during labor.
Okay.
And just for my colleagues in Tanzania, I always have to do a conversion because I know we do the milligrams in deciliter, and then in Tanzania we do the millimoles in liters. And so between 60 to 100, that would be 3.3 to 5.5. That's the target blood sugar that we're talking about. And just to add on to that, obviously, as a pediatrician, if I'm called to a delivery in this scenario, you know, as a patient that has had scant prenatal care, is a diabetic, I'm obviously worried about, you know, birth trauma to the baby. If it's uncontrolled, I'm thinking, you know, how large is this baby? It could be large or it could be small. Either one of those can happen. And if they are large, you know, probably C-section might be the preferred route because you could have dosha, you could have asphyxia with pretty bad acidosis that comes along with that. And not just the injury to the baby, but the injury to the mother as well during this delivery. And then other, you know, complications that I have to worry about in a child that, you know, a baby that's born to a mother that was uncontrolled is these children are more at risk for respiratory distress. They might have cardiac anomalies as they're born. So you have to be ready to deliver an infant that might have a lot of complications. Hypoglycemia becomes lower on the, you know, on the chart of complications. At this point, I'm just hoping we have a healthy baby. And then after the baby is born, then we can worry about some of the things that we have to worry about when the newborn, you know, comes around.
Dr. Mkony, what do you usually, I mean, as a patient, what do you usually want to see from the OBG? If they're giving you reports, what do you want to hear or see before that baby is born for you to be prepared for that baby? From your experience.
Thank you, Harriet and the team. So for me, as Lilia has said, IDM babies, I'll consider them high risk in a way, especially in a setting where diabetes was poorly uncontrolled, because there is a good chance you can have a baby with all those complications as what she has mentioned. What I usually prefer to chat with my junior colleagues when I'm teaching them, like in undergrads, when you see a woman that has a gestational diabetes, anticipate all the complications that the baby can get on the baby perspective. That sugar can affect the CNS. You might have problem on the CNS, spinal, like spinal problem like spinal bifida and encephaly. You can have issue on the heart. You can have congenital heart diseases. And that's the thing that you'll be looking at when the baby is coming out. On respiratory system, the baby might have like a transient tachypnea of the newborn to RDS, much as it is term, but high levels of sugar deactivate surfactant. And that is why that baby needs to be looked on the respiratory wise. How is the baby breathing? Is it normal? Is it okay? And the baby might look nice, pink and chubby. Usually they tend to have a smally face. And even if you don't have, like, for example, it's a mom that never booked and just came in, which is a common scenario you might encounter in Tanzania. She just comes in labor and you receive a 3.8 kg baby. If you see a nice chubby baby with a smallish head, just think of gestational diabetes and keep your eyes wide open. And then you can also have some problems on the renals. So try to see if this baby is passing urine at least to start with. And 48 hours, the baby is not passing urine, is sickish, try to see the renal function test. And one thing that I know it's common, once somebody mentioned gestational diabetes, sometimes one might be scared and said, okay, I need to take this baby to the neonatal unit and separate baby from mom. That might be not very correct direction, because that baby needs to feed unless he's having a condition that needs to be separated from mom, and allow that mom to breastfeed a baby, keep on breastfeeding while we are monitoring sugar with the mom. Because the moment you start introducing your IV fluids, you're going to dance to the tune. The sugars are just going to be up, left, right, and center. And that is one thing that you don't want. So if it's a well-controlled baby, I would wish the obstetrician to tell me what has been the sugar levels, as what my colleagues have mentioned. And it will be good to have a pit still to receive the baby if possible. And if the baby comes out like uncomplicated, allow the baby to stay with mom, but make sure you go and see the baby after at least within 6 to 24 hours, if no problem. And because they are nice and chubby and pink, the HB is usually high, so they have polycythemia. And much as it's a tame baby, the moment you have your high HB, think of jaundice. And that is one thing that you can easily miss, because we tend to think jaundice is very much more common preterm babies, but it can happen to tame babies. So just keep your eyes open and see, is my baby becoming jaundice? So less is more, and yeah, small items, they can sum up and you might have an issue. And being a big baby, again, if it's like a smallish mom and monitored labor, they can have meconium aspiration. And being again a chubby baby, inactivated surfactant with meconium aspiration syndrome, PPHN settling in. So you might have like a sort of a dual thing happening on the lungs. The surfactant is being inactivated, but also meconium is causing issue. So that's what I can see on the pediatric part of it. So diabetic mom, an infant, just uncontrolled sugar. Just know that sugar can do a lot of things on a baby, and as a pediatrician, you need to be prepared and anticipate complication and address them accordingly as they come along. And someone can be lucky, the baby came out as if nothing was happening and you're just worried, which is a good thing for the baby and good for yourself, because you brushed up your memory.
Dr. Kabibi, what from your experience, what are the things that you've noticed, either if it has been addressed in pregnancy time or intrapartum? What are the things that you discussed on the after the baby is born?
I would like to talk about maybe the practice, which when the mom is ready for delivery, at the time when you communicate with the obstetrician, they will tell you that they have a mom who has gestation diabetes, and sometimes controlled one. Some of the time we take those who are coming in while they haven't visited the antenatal clinic, and sometimes you might also get to those who don't even know that they are diabetic. And you just find that the baby is big, and sometimes you get those microsomia with pelvic trauma, especially for those who just come from home and they want to live normally. But for those who have been planned, most of them will end up with this cesarean section, which is a good part. So for us also to take care of the baby and the mom, to avoid the traumas and other complications. We get those babies most of the time with low blood sugar, hypoglycemia. So we usually start with giving them IV fluid. And remember, when the mother is as a C-section, an operation, it's not easy for them to get breast milk baby. Therefore, we usually start giving them immediately the 10% breaststroke, which is running continuously at least 24 hours. Without the breaststroke, you can get only about 60 minutes per day. And you need to with a ringless blood state so that you can avoid the electrolyte imbalance. Most of these, they stabilize at 48 because after 48 hours, most of the mothers, they get the breast milk. Therefore, we encourage them to breastfeed as much time as possible. That's the easiest thing. That when you are using the erythroid only, the possibility of getting hypoglycemia, hyperglycemia is very most of the time we get that. Therefore, we encourage the mothers to breastfeed most of the time. And when they're breastfeeding, they can't otherwise, sometimes we get those respiratory distress, whereby the child is being taken care of. Sometimes we give them antibiotics because we are not sure if also they have an infection, also for the prevention of any infection which the baby can get. I will thank God that at the end of the day, most of the diabetic kids will get it. And we follow them at least for 3 months, 3 months of age to be sure that they're safe. Yeah.
Even for us, when they found that there was this health complication of this kind of cases, we do follow them by doing ultrasound and cooperating with this gynecologists or obstetricians. We arrange when they are doing C-section. We as surgeons also are supposed to be around, and after soon after delivery, we can do repair if it is small, can do it just right away and after delivery. But if it is big, we do arrange the repair mask and use mesh, or we use skin grafting, then we cover the defect of the hospital.
Thank you, Mr. That's the part of which I was going to go after the Kabir. As a surgeon, because what the Kabir is saying, more likely the mom is going to have a C-section. So from your standpoint as a surgeon, what would you, either if you have an opportunity to advise the OB/GYN, I know they're not here, but if you have an opportunity to advise the OB/GYN, thinking of a mom who has gestation diabetes from the standpoint of the surgeon, what are the things that you think that if they should have done that, if you make safer for the patient during surgery, then it will be prepared for that?
Yeah, it's very important if we have also theory of antenatal care, which operates also the surgeons. So we prepare for what you can do right away after delivery. If that we make sure we don't lack any material which can save the to build the area of side range, not drain as many patients here in our locality. They come with this kind of treatment, maybe 6 months or 1 year after delivery. But if we do follow before delivery, this could be or could help them very much. The management.
Okay. Thank you. So I'm going to go back to Dr. Mkony, continue for the part of the cardiovascular. So having those babies who are already compromised, being in the NICU, what are the things that you see could help as a labor and delivery nurse, for example, things that I can do to help that baby when they have something like that, spina bifida or any congenital anomalies or any complication that they have at that moment? What are the things that we can do to prepare or anticipate care? Dr. Mkony. I was just finishing saying about the spina bifida. That's one of the complications for mom who has gestation diabetes, and that affects the outcome of the baby. So I've been working with the NICU, majority of the NICU babies with those complications. What are your suggestions?
Cardiomyopathy and uncontrolled diabetes in pregnancy has been associated with the development of complication in various systems, and CNS is one of the areas that is being affected. So if you have a baby with a neurotube defect, you'll just manage the baby as with a clinical presentation. Okay, unless the mom is presenting with uncontrolled diabetes, then you might anticipate maybe it is related to that one, but the causal relationship, like clearly establishing this neurotube defect is because of diabetes, uncontrolled diabetes, or it's because of like a folate deficiency or another thing. Most of the time, it's not the diagnosis that we go and do, but to manage the baby depending on what they present. So if a baby is presenting with a spinal bifida, then you manage this as it is presenting, and we don't tease out what is the cause of it. I don't know if I'm answering the question. And in a Tanzanian setting, most of the time the neurotube defects, we do conservative management unless they present with an emergency. And most of the time, the emergency will be like a rupture of like a myelomeningocele. If it ruptures, then it needs to be referred to a neurosurgeon for immediate repair. And what we usually tell mothers, like whatever surgery is being done is mainly, should I say, cosmetic, just to make the baby better, but it's not going to restore the neurological deficit the baby is already presenting with. And that one can also be associated with hydrocephalus. So again, it will be only controlling the complication of hydrocephalus, not making it progressive by putting a shunt and so forth. But yeah, so mostly what I see in Tanzania is conservative management. Usually start with doing daily dressing on the affected area until when the skin can cover the area. And once the baby is like reach a certain age and is well enough to travel, because I know most of the repair is being done at Muhimbili and probably Dodoma, then they'll do something about it. Here, they tend to do a little bit earlier in Cape Town and probably in some other parts of the world. So it always depends on what the baby is presenting with and where is the baby.
Thank you, Dr. Mkony. So I'm gonna, we are lucky enough to have Dr. Kitanga with us here. Yes, he's a physician. So I'm gonna ask him, we're discussing about the gestation diabetes, its impact in the pregnancy and affecting the desired outcome for our babies. So as a physician, have you encountered the patients with the gestation diabetes, and what can we learn from your experience with interacting with them?
I think gestation diabetes is not that much common, but to a certain extent, we see patients with diabetes, and some of them they may accidentally be diagnosed during their clinics, and because I think it isn't a very routine thing done as a baseline investigation for all women with pregnancy. But on the other hand, we do urinalysis on the cause of as a routine thing, where accidentally someone may trace some blood sugar. Unless someone goes to a specialized clinic, a gynecologist or whatever, someone may, with another underlying maybe condition or reason with their pregnancy, then some thorough investigations are done. Whereas maybe the gestation or whatever associated diabetes with pregnancy may be diagnosed. We are managing them, and the outcome to us is good on that side. Once we get a patient, maybe it's easy to make follow-up counseling about the diet, which is the main stay of management, and most of them we shift them from oral hypoglycemic drugs, as some of the research have shown the relationship of some congenital anomalies with the usage of oral hypoglycemic drugs. So what else?
We have encountered the patients with gestation diabetes, and from your experience, what can we learn? Because if you have seen the other side, like somebody who has gone through it, and then you see them after delivery as an adult. So things that we can learn from your experience. So, for example, as a labor and delivery nurse or OBGYN side, I can make sure I address it so the outcome is better when you see them afterwards.
Because the outcome depends on the management based on individual.
Yes.
And the good thing to do, the best way to do is to educate. Education is the first, I think, approach. So giving a person understanding and how to manage, especially in diet. And maybe I think follow up and doing when I just always tell them they should understand a reason why they prick themselves and get the results. They should be able to interpret the results and to say whether the results are good or not good. If they're not good, what is it? They need to know what is making their diabetes uncontrolled. What is making their diabetes not good? And they should know about their outcome if you can control diabetes to a fetus, to themselves. And it's very costly for them to manage complications which are resulting from diabetes. And I believe management of diabetes is patient-centered, but the best way is to educate.
Thank you, Dr. Kitange. I'm going to go back to Dr. Msambichaka. Dr. Kabibi just gave us activity that usually they do, like a protocol they do after the baby is born, and what are the things that they need to watch and continue watching. So from your standpoint, what are the routine things that you do for the newborn who is born from moms who is a diabetic?
Okay. So the way we do it here is every newborn that is considered high risk for hypoglycemia is identified at birth, and one of those being the infant of diabetic mothers. But in that category, we also include small for gestational age, we include the large for gestational age, we include the late preterms or premature if they meet the criteria for the regular nursery and not the ICU, the neonatal ICU. And we, within the first 30 minutes of life, we encourage a blood sugar screening. We should not go more than an hour. And the child should be put on the mother's breast within the first hour of delivery, whether it was if it was a C-section delivery and there's no, mother is still unstable and cannot feed, then we figure out a way of feeding the infant, whether we have to do formula feeding or just check the blood sugar and see how long you can delay the feed. But the moment the mother is stable enough to feed, then we encourage feeding. We have protocols so that it's kind of everybody knows they're doing the same thing. Our protocol divides it into two categories: the first 4 hours, and then from 4 hours to 24 hours. So the first 4 hours, the blood sugar that we aim for is, a blood sugar less than 25 in a newborn is considered critical. And 25 for, I guess that would be around 1, between 1 and 1.5 from a conversion standpoint. That is considered a critical blood sugar. But anything greater than 25, which is the same one, between 1 and 1.5, is considered acceptable in a newborn. But 4 hours later, our target shifts because at that point we expect some physiologic changes to have occurred, and therefore we aim for a blood sugar greater than 45. So between 0 to 4, and then we have 4 to 24. All our babies are monitored for 24 hours at a minimum, and they get blood sugar checks before they feed. We have a protocol where if the blood sugar falls below the established guidelines, then the mother is encouraged to feed the baby, and then we check for response, and then we kind of repeat that process. Instead of going straight to IV fluids, we do feeding, either it's breast or bottle, or we do use glucose gel, which we rub in the cheeks of the babies. And it's just concentrated sugar, like 4%, 40% dextrose. And if that fails, so you feed the baby, you do formula, you do the dextrose gel, and the baby remains persistently hypoglycemic and symptomatic, that's when we transfer the babies to the NICU for IV dextrose administration. So it's very rare. Most of our diabetic diabetic mothers, it's very rare that we put them on dextrose IV fluids, and we try and manage them as much as possible on the newborn nursery so that we don't separate the infant from the mother.
So Dr. Mchaka, you spoke about the we spoke about the babies monitoring the glucose after the delivery. So if we just jump to the second scenario, that the baby who was 30 weeks, and then now, so you're taking care of this mom who is diabetic, and then baby's less than 30 weeks. And then, so what are the things that you want the OBGYN to do, to prepare that baby who's going to be born premature for you to come and take care of this baby in the NICU? What are the things that they should do?
For the baby or less than 30 weeks?
Yes.
So at my institution, that would be something I would be asking Dr. Mkony to actually manage, because those are considered too premature for a regular newborn nursery. But the protocol would still be the same. There should be a pediatrician at the delivery, somebody that has capabilities to intubate, because chances are that child might actually go into some sort of respiratory distress. Even at 30 weeks, it's unlikely that they would probably need a C-section. It would probably be like a routine vaginal delivery. But I would prepare myself for all the other stuff that we talked about. So I would like to know, was this mother, diagnosed gestational diabetes, controlled or uncontrolled? What were the blood sugars? If they did not get any routine care, then I'll just prepare myself for the worst case scenario. Ready to intubate, think of cardiac anomalies, think of CNS anomalies. I would prepare myself for an infant that is in distress. I would probably say if you're anticipating delivering a 30-week-old infant, and I don't know what my colleagues, who's available for deliveries at that facility, but at least I would have somebody who has capabilities to resuscitate a newborn.
Thank you, Dr. Mchaka. So I'm going to pose that question to Dr. Mkony, because you just directed part of the question. So Dr. Mkony, for your experience, either from Wimbi or where you are now in South Africa, what are the things that preparing for a 30-weeker or less than 30-weeker, what do you want to see done for that before that baby is born? Because usually, as a labor and delivery nurse, we know less than 34 weeks, so then we're going to give this mom steroids. So now the complication comes for a diabetic mom, and you know the steroid is going to impact the glucose. So what do you need to do to prepare for this baby?
So as Dr. Msambichaka said, this is a high-risk baby, and you should be prepared for the worst complication. And for us, newborns, respiratory is the worst complication that you anticipate. So you should have your resuscitation equipment ready. Currently, we are trying to go away with the intubation, so you should have like like I'll talk in a Tanzanian setting, you should know that you have your oxygen source ready, your bag and mask. If you're in a setting where you have a neopath, then you should have the correct appropriate size. The baby might come maybe a little bit large for gestational age because of the gestational diabetes. Babies tends to be a little bit big, and yeah, so you should have that one. And again, because of being premature less than 30 weeks, they are prone to have respiratory distress syndrome. Coupled with IDM, it's likely that they're going to have respiratory distress syndrome. So surfactant should be ready just in case the baby is not well stabilized with CPAP care at delivery in the neonatal unit. This is the baby that is likely to be separated from mom, i.e. is going to be admitted in the neonatal care unit. And the unit that is going to land will depend on the initial clinical presentation. Might end up in like a NICU because of the severity with imminent intubation pending, or in a less like a step down high care or something like that, but with a close monitoring of the respiratory distress. And there's a good chance that is going to need some oxygen support in the transition, unless was a steroid matured. And okay, another thing that I'll be looking at is the sugars. If it was uncontrolled mom and has received Dexter, then you might have some derangement on the sugar. So I'll just keep my eyes open and see what the sugars is doing. And again, feeding is very important. So whatever mom can give, it's okay. Colostrum is very important to feed this baby for one, priming the gut, but also minimize the risk of getting neck, because formula feeding this baby is not that what you want. So I'll encourage mom, even if the baby is separated from mom, to try and express and give me that single golden drop. I usually call it like a golden milk, and whatever mom can give me, that will be good. And should I start feeding this baby, I'll probably be skeptical on starting on formula and opt for breast milk as the first initial feed to avoid the other complication like neck later on. So in a summary, prepare for respiratory support. You need to have your bag and mask ready. At 30 weeks as a preterm baby, so you might need, if you don't have an oxygen blender, then just connect that bag and mask to oxygen. If you have a blender, baby's having distress, you can start titrating with a 25 to 30, and then transport a baby to a unit where oxygen respiratory support can be done, and you monitor saturation, ensure that you have a sat list more than 90. And B is the second thing that you need to control is the sugar. Make sure that you have an acceptable range. And for this baby, I'll go to anything above 2.6, I'll be comfortable. And another thing, the third one, you need to feed the baby and enteral feed, preferably mama's milk, and whatever she can give, that is what you want to do. And obviously, yes, update mom and make sure that she's involved on the plan.
Thank you very much, Dr. Mkony. I see some.
Yeah, this is Dr. Mlawa, yes, from London.
Okay, thank you very much. I know you asked a couple of questions on the chat. Can you verbalize this so then they can hear the question, and then we get a good doctors to answer it?
Sorry?
I said I just saw a couple of questions in the chat. You wrote them. Can you ask one of the question live so the good doctors can answer you? And Miss Nancy?
I think the question was directed towards my colleague from Tanzania. And I know that there was a mention of the use of oral hypoglycemics. So I wanted to ask which oral hypoglycemics are they using? That's all. And that's number one. Number two was if the patients got diabetes in pregnancy or gestation diabetes, how often do you follow them? Number three was if the patient is a new gestation diabetes, but previously not non-diabetic, postpartum, when do you follow them? That's the third question. That's for my colleague from Tanzania.
Anybody want to volunteer?
Usually in pregnancy, we really avoid using oral vaccine because we know they don't have good outcome in some cases. But as they've said, is you follow the patients, to train them how to follow themselves, and is there any uncontrolled condition that may be monitored, maybe during monitoring may be suspected, a patient should come to the hospital for review. But usually they do have a routine, a tendency to antenatal clinic where they come with their records of their blood sugar control while at home, and we do the urinalysis, we do the blood sugar control, we do the HB1AC, the hemoglobin, just to see whether they stay in controlled status of their glycemia. Oral hypoglycemic drugs, we avoid them.
So from Ms. Nancy, in the US, what medication do you use for the during the antepartum period when the moms needs medication?
It's going to depend on how severe the hyperglycemia is. If the hyperglycemia is severe, we would always use insulin. We used rapid-acting insulin, Humalog, Novolog, and we used NPH before breakfast and then before bedtime. If they were mildly hyperglycemic, we could start with acarbose 3 times a day and titrate. Or we could use glyburide 2.5 twice a day. And then recently, metformin had become approved for pregnancy. We would use more metformin and we would titrate usually up to 2,500. I've seen in the literature that it's safe to go to 3,000 milligrams per day. We brought the patients in if they were uncontrolled on a weekly basis. If they were fairly well controlled, we would bring them into the doctor's office every other week. On the weeks that they were not seeing the doctor, they would call their blood sugars to the diabetes educator. And then if adjustments were necessary, we would adjust either the oral agents or the insulin at that time. We would teach them if their blood sugars were rising, more than 3 days in a row, to please call the diabetes educator and not wait until the doctor's appointment for the adjustment, to keep the baby safe and to keep the baby from becoming large for gestational age.
Thank you, Ms. Nancy.
Did I answer the questions?
Yes.
Okay.
Did you have anything to respond on?
Yes. I know there are studies which have been done on usage of metformin in pregnancy in South Africa, where they found that the side effect of or metformin in pregnancy is very minimal, and so they are using that. But I don't know, maybe we need to do more research in our settings to find out. We can say about the usage of oral vaccine, especially metformin. But we know metformin promotes the insulin metabolism, and also even used in pre-pregnancy people just to promote the fertility on that side. But I think something that we need to find out, to go further and get more studies on it.
Okay, thank you, Dr. Thank you. Dr. Mlawa, I see your hand is raised. Did you have to say something about the medication?
Yes, I just want to share what we do here in UK in terms of whether it's gestation diabetes, that is someone not non-diabetic, but they become diabetic during pregnancy, about diabetes in pregnancy, whether they're type 1 or type 2, and what we do. Normally, if somebody is known gestation diabetes, initially they are seen in a joint diabetes antenatal clinic, and with that, they're seen by a dietitian, they're seen by a diabetes specialist nurse, and they're seen by a diabetes consultant, and also obstetric team. Initially, we can start them with diet, but the follow-up is very strict. It's initially once a week, once every 2 weeks, and based on how they do, we can introduce metformin. Actually, metformin is a very safe drug. It has got a very good safety profile. We've been using for years here in UK. And based on how they do, then you can introduce insulin as you go along. But the follow-up is very strict. It's once a week, once every 2 weeks, and then you know that maybe they're doing well with diet alone or they're not doing well. For type 2 diabetes patients who are known type 2, initially they were taking oral hypoglycemics, such as the metformin or glucoside, for instance. We always keep the metformin and then start insulin. So once they are pregnant, we stop all other hypoglycemics, but we introduce insulin on top or as add-on to metformin. Metformin has got a safe profile. Then for those type 1 diabetes patients, if they become pregnant, of course, we optimize what they're taking. They're on insulin already. But in terms of these patients, those who are non-diabetic, we've got it's called counseling clinic before becoming pregnant. So we try to advise them to get pregnant when their HbA1c is less than 7, for instance, in terms of order, less than 7%. So we've got a very good structure looking after patients with diabetes in pregnancy or gestational diabetes in the form of a joint antenatal obstetric clinic and diabetes team, the so-called MDT clinic. So it's a very good setup and throughout the country in UK. And this helps in terms of supporting these patients during pregnancy to make sure that we avoid complications such as macrosomic baby, shoulder dystocia, and the unnecessary C-section. Thank you.
Thank you very much, Dr. Mlawa. Yes, Dr. Kabedi is going to speak.
But I would like to know from Dr. Mkony and Dr. Msambichaka, especially for preterm babies, within the first 24 hours, our mothers are not having even a drop of breast milk at the first 24 hours. Therefore, are you encouraging that to use the formula milk? Because I'm fearing of the milk. That's why I usually use IV fluids, especially at the first 24 hours before the mother is awake and can do also some drops.
I can start and then I'll defer to Dr. Mkony. So the way at my institution, the way we're set up is we do have the luxury of having what we call like a level 3 neonatal ICU. And so our extreme preterm babies end up going there anyway. And they usually go there for other reasons, whether it's respiratory distress or rule out sepsis or something else that takes them there. But on the regular newborn nursery, we do take care of, so anybody between the like 34 to 37, so less than 37 weeks and greater than 34 weeks, we do take care of them on the regular newborn floor. And we don't do IV dextrose that often because the colostrum itself, as long as they're doing frequent breastfeeding and their blood sugars are not critically low, it is able to bring up the blood sugars. And the complication for neck is very, very rare in that age group, at least at my institution. And so we are more liberal if the mother is not able to bring up the blood sugar just with the frequent breastfeeding, which is mostly colostrum, like you said, they're not making any milk at that point, then we do supplement with formula at that point. If we can't, and then the other thing that we do is we do dextrose gel. So we don't do IV dextrose. We have this, and I can share it with Dr. Drgabone, and she can share that with you. So it's just a gel that's sugar, it's safe, it's concentrated, and we rub it in the cheeks. We have a protocol in place. We can only use it twice while they're on the newborn nursery. And if we, despite trying breast milk, dextrose gel, formula, the child still has significant critical hypoglycemia, then we transfer to the neonatal ICU, because one, it's either we're not just dealing with gestational, the hypoglycemia from mother being a diabetic. We might be dealing with hyperinsulinism from something else and other etiologies that might be causing the hypoglycemia, and sepsis being one of them, because obviously that can also lower your blood sugars. So for the most part, greater than 34 weeks, we rarely see NEC, at least at my facility. We rarely take them to the ICU because breastfeeding, frequent breastfeeding usually resolves that issue. And I can let Dr. Mkony speak to the more premature infants, the 32-weekers and below, because obviously that's a whole different process.
Thank you, Dr. Msambichaka. So I'll talk on based on experience that I have in Cape Town and an experience back at home. So in Cape Town, we have, for a baby that is eligible to feed, less than 1.5, we have donor milk. So we can start with donor milk, and mom will have to consent for that. And it has been a well-accepted thing, and with an exception of our Muslim colleagues, some of them, based on their faith, they won't accept it. So we have an option of starting with donor milk. We try as much as we can to avoid formula. But if a baby is more than 1.5, then we can start with formula while we encourage mom to give EBM. Back at home in Tanzania, two practices, I would say. One is they'll go for IV fluids. We don't have Dex gel. It's something that we have learned, and we are trying to discuss with our colleagues if they can compound it, because it's something that can be done. I know, like, our colleagues in US are probably using 40% dextrose gel. We have been using 50%, but we'll see what can be done. And we tend to discourage other places, because I know some places they'll give like oral dextrose, like D10, which is less in glucose, and they sort of give them regular, not like what you guys are saying. You're giving it if the baby is having persistent hypoglycemia after 2 dex gel, then they'll need to be managed for hyperinsulinism. In some places that is not a practice, but what they'll do in majority of other places is like a continuous D10. The experience that I've seen in Cape Town and Tanzania, I don't know what is happening, is an area open for discussion. I've never seen a lot of persistent hypoglycemia in Tanzania as what I'm seeing it here. So I don't know why, but it's one thing that I see. We don't get to see a lot of persistent hypoglycemia in Tanzania than what I'm seeing here in Cape Town. And the issue of breast milk bank, I know it could be a new concept to my colleagues at home in Dodoma, but back in the days, the senior colleagues will know wet nursing is something that has been done. First time that I knew about it was when I was in Bugando, when I was doing my internship in 2007. I remember we'll identify a woman after being tested being HIV negative, and if we have a micropremy, and there's another baby that does not have any milk, so we'll ask her if she will agree to express for both 2 babies. And most of the time they would agree, because you just feel sorry for the young one and they don't need much of your milk. So they'll do like maybe 3 or 4 meals every feed, and it's nothing extra. In fact, that would also help the mom that is expressing for the other baby to have more milk, because the more you express, the more you get. And something that is a project that we are tackling now at Muimbili, my colleague at Mloganzila is doing a feasibility study to see the acceptability of human milk bank, and maybe in the coming year, probably 2022, 2023, we might start with a human milk bank. Informally, we have been doing it, requesting moms to donate their milk to the other baby, or at times moms will make their own arrangement, provided the doctors would allow it. But this is on a very special occasion. It's like it's not a common practice and is not stipulated by the ministry. So it's something that we are thinking of going to the donor milk. Issues of neck, we are seeing gastritis, we are seeing neck, and again, sepsis rate in Tanzanian setting, in sub-Saharan Africa, it's something that is high. It's a third killer of a newborn death. And a lot of things have been coupled. I'll say one is we have not been able to control the infection, the hand washing hygiene, something that we need to learn. And also prolonged exposure to antibiotics that is not required. We are changing the gut microbiota, and that by itself predisposes a baby to get an infection. So if you have a premature baby that's been to antibiotics because they don't need it, and it's probably a trend, my colleagues might agree to it. A premature baby, if he's admitted in the neonatal unit, chances are it's going to get antibiotics for the fear of like, baby might get so sick, might get infection, and we need to do something to help. Not knowing that by just exposing this baby to antibiotic who doesn't have an indication of getting antibiotics, you're changing the gut flora, and that would predispose them to get late onset sepsis. And that is the one that is responsible for a baby to get neck. So we do get neck, and at times you do get perforation. I'm talking for the experience at Muimbili being a referral hospital. When you get babies with a bad sepsis, they end up with perforation. Not so many, but I've seen some cases. And also a similar experience here. And what I've seen again, for the babies that are getting neck, for example, with perforation here in Cape Town, some of them, they tend to have prior predispositions to formula, or there was predisposition to sepsis. I mean, like antibiotics, and like this was a baby that was extremely sick and had a lot of issues, like bad acidosis at delivery, had to be on antibiotics, was not well fed, like it was a cluster of symptoms that predisposed the baby to getting a secondary bacterial infection while in the NICU, and if it's not well controlled, you might end up with perforation. I hope I answered the question.
Dr. Mkony, what's your age cutoff for prematurity needing, where you guys avoid formula? Because I know you're probably, being the NICU, you probably see most of the neonatal ICU patients, but what is your cutoff for newborns that are just taken care of, like on the newborn nursery versus the NICU? We have a distinction, we have like a weight. If you're under 2200, you go to the NICU regardless of your gestational age. But if your gestational age is like 34 weeks and above, you can stay in the regular newborn nursery and you don't have to go to the NICU. And those babies, we do give formula more than obviously our NICU colleagues who have to take all, the babies in the NICU are sicker. They have all other reasons to be unstable and to worry about all the other things that you talked about.
So I'll talk on the two experiences. In Cape Town, a baby less than 1.8, less than 34 weeks is going to be in the nursery. And depending on the other clinical presentation, might be upgraded to the NICU. Back at home in Tanzania, 1.5 is a baby that is going to go to a nursery. And depending on the clinical presentation, again, will be escalated to the appropriate care. At Muhimbili in particular, we tend to discourage formula. It's a baby-friendly hospital. So we tend to encourage much on the breastfeeding than formula feed. And we'll only give formula to the, for example, orphans or a baby that we know for sure mom is unlikely going to breastfeed for the next 4 or 5 days. For example, an eclamptic mom in ICU, we know chances are that mom is not going to be ambulatory anytime soon, and we'll tend to give formula. At times we do give a top-up formula from what mom has expressed. Don't get me wrong and don't quote me anywhere. What I've seen, public patients tend to produce milk far much better than a private patient. And this is because I have an experience of working a little bit on private practice compared to public. A mom is coming from like Mbagala, for those who know Tanzania. You ask them to give them 10 meals, they'll give you 15. A high-class mom, you ask them to give you 5 meals, they'll give you a drop and they'll cry, their breast is sore and they cannot give you milk. And so, you know, they have this formula that has been given as a present by their friends and they'll stick to formula. So that is what I've seen. And yeah, so it's different. And I cannot say who has milk and who doesn't, but I know every woman who has just given birth, prolactin is settling in. You put the baby on the breast, you can get. Another thing that we have been practicing at Muhimbili, even for very sick babies, we have been asking moms to give us colostrum for oral swab, and that one has tremendously improved our breastfeeding rate. A mom comes, the baby is too sick, we tell them, we do the medical part and you do the baby part. And by doing the baby part, just squeeze a drop of milk, put that on the baby's lips like you're applying a lipstick, and that is more than enough. And we all know the normal flora that is colonizing the breast is very good. It's lactobacilli, is the other normal flora that is important for the gut maturation. And that by itself has improved significantly on the breastfeeding rate and reduced the rate of late onset sepsis and therefore NEC. So by just asking mom from day one, soon as after she ambulates, the mom will ambulate, let's say 8 hours. Ask mom to squeeze that breast, put the baby on the breast. Baby is not on CPAP, let the baby latch on the breast, let the baby lick. And by that stimulation by itself, it will sort of precipitate or encourage mom to produce more milk. And by the time the baby is able to take 5 meals, you would have that amount. So that has been my experience and it works perfectly fine. In fact, you can manage. If you delay a little bit, for example, that you are worried on, I'm skeptical to start baby on formula if I have a high lactate on a gas, because I have a luxury of doing a gas. So if I have metabolic acidosis or I have an acidotic gas, I'll be skeptical to start a baby on a formula and delay it a little bit, allow mom to come, give colostrum before I start my formula feed. And that one works well. So encourage those moms. I mean, if you tell the mom, this is what your baby needs and this is the best thing, maternal instinct kicks in and mom will be able to give you some milk.
Thank you very much, Dr. Mkony. So we're specifically baby friendly means like you use the formula, the physician or they have to almost like subscribe for the baby. So we did as nurses, we were feeding them. I mean, babies born within an hour, you have to put the baby on the breast. If mom cannot breastfeed for any reason, either they're sick or still maybe they're on operation, so we encourage mom to pump. As soon as they come to the recovery room, the first hour she starts pumping. And then so we do the gel like what Dr. Sambichaka was talking about. We keep the glucose above 25. I'm sorry, less than 25, then baby will get the IV fluid, but more than 25 and less than 40, then baby will get the breast milk first, and then we have to supplement if needed. And then we manage the glucose like 15 minutes to 30 minutes after the feeding of baby. And then we check the glucose, make sure it stays above 45 by the time it's 24 hours. So there's specific things that we have to do to keep up those glucose levels for these babies.
Did you have a question, Ms. Valentine?
Oh, yeah, so after listening to everything, I was just going to ask if they can share some examples of the type of education and things that are done during the prenatal period to try and prevent all of these complications that you anticipate. So for example, what would you teach like your patients to what type of diet would you teach them, and like as far as weight gain, what are you expected to see every trimester just to kind of regulate their condition so that it won't lead into something more severe later on.
Okay, so for the last part, I know Ms. Valentine did ask about education. So if anybody can just give us a few minutes to say something that we can learn, and then we can educate our moms and prevent the complication for these babies. I'm gonna start with Dr. Kabibi.
Almost all the things that have been mentioned. It won't be able for me to mention about the prenatal or
which is fine.
antenatal. I do on my pediatric part. Soon after delivery, we usually talk to the mother, be ready for producing the breast milk. And we encourage that so much. As I said, in the first at least 24 hours, we might be using the IV fluids, especially 10% dextrose. And after that, we keep on encouraging the mother to produce the breast milk. And the baby, most of the time, if the baby is not on oxygen, is stable, they stay with the moms. And also, we link with the physician to talk about with the mother about the diabetes, so that she can be stable. Also, the baby can get the milk. Because if you deal only with the baby, the mother gets stressed, and sometimes they lose that ability to produce the breast milk, which will later compromise the baby. But we are, it's a very little use of formula milk. Sometimes we use them if the mother keeps on not having enough milk. But on my part, I usually do that. And to follow up the baby, as I said, for the time when the mother is in the hospital, they're being discharged about 5 to 7 days post-delivery for the stabilization of the their diabetes, of their blood sugars. Therefore, we also have time to take care of that baby. And after that, I will follow up the baby at least once in a week to follow on blood sugars. Otherwise, things like that.
Okay.
We usually don't get much complications 24, 48 hours post delivery of the baby.
Okay. Yeah. Thank you, Dr. Kabibi. Dr. Tangi.
Yeah, I think the best. I think we just to set the goals for the pregnant women with diabetes or any other person with diabetes, just to understand what is the goal is to control the blood sugar, and controlling its goals. For case of a pregnant woman, it's a teamwork, it's multidisciplinary. As you see, there's pediatrician, gynecologist. A woman may at the time need a nutritionist and go to a therapist and all this. To understand, just they have to meet their goals. Even the family must be involved, especially husbands and other people who are living together with the pregnant woman or any other person. So they have to understand that they do things which are supporting a patient and controlling, especially in terms of nutrition, in terms of making sure that they take their regular drugs, reminding them, supporting them, but the mainstay is the education. It's the most important thing to understand and to know when they're well controlled, they won't go to complications. They won't go to a baby who has complications with. big babies and other respiratory complications and other malformations. I think that will be the best way. And the regular checkup, very important. To identify sometimes the signs and symptoms of uncontrolled blood sugar or a crisis. They may go to hypoglycemic crisis during the pregnancy. So they need to know. And when they have to test themselves, interpret by themselves in a proper way, the outcome, and be able to predict what are the common causes of them not being controlled. So they can always avoid such a situation in the cause of the disease in life. Otherwise,
Yeah, thank you very much, Dr. Kitange. Going back to Dr. Msambichaka and then Dr. Giving Ms. Nance.
Usually from a pediatrician standpoint, once in most cases, blood sugars are stabilized in 24 hours. And so, we mostly try to, assess for any potential congenital effects that uncontrolled blood sugars had on the infant. So, during your exam, try and see if they have any signs of like a congenital heart disease. We have the fortune here of screening every child at 24 hours for critical congenital heart diseases. I'm not sure if my colleagues in Tanzania have that capability. If a child prenatally, we try and get a fetal echo on every mother that has diabetes, just so that we are prepared postnatally to make sure that the child did not have some sort of congenital heart disease. If they did not have one, then obviously a good physical exam on the baby, making sure you don't hear a murmur that you think is more than just the transitional murmur that you see. You don't see any cyanosis. Just the routine stuff, educating parents about, obviously by this time you would have had that information. Has the child voided? Has the child passed meconium? If the child, had delayed passage of meconium, having it in the back of your mind that this is a child that might need to be followed up more closely. They might have Hirschsprung that's mild, and you're just, and that's the only subtle presentation. But for our part, once the acute phase is done, which is making sure that the blood sugars are stable, then we just do the routine newborn counseling, which involves feeding the baby and monitoring for any signs of infection. We screen for jaundice, and so educating the parents on signs and symptoms of neonatal jaundice. Actually surprised that our colleagues have the luxury of having patients in the hospital for 5 to 7 days. We're kicking them out the door, like 2 days. They're out the door to care for these newborns. So, anticipatory guidance, we're very big on that, just preparing these parents to see what they can watch, what they should be watching out for. And that's mostly just like routine newborn stuff at that point.
Thank you, Dr. Msambichaka. Yes, anticipatory guidance, a big word. Dr. Mlawa.
I think from my side, I'm grateful that you invited me to attend this meeting. But what I want to see, as far as Tanzania is concerned, in terms of management of the so-called gestational diabetes and diabetes in pregnancy, is for the future to do this in a form of a multidisciplinary team. I have spoken to my colleague before, Professor Pembe at Muhimbili, to try and float this idea of having an MDT team to look after these patients who are very special with diabetes in pregnancy or gestational diabetes. I think that would be the best practice. But I know that back home you are doing a very good work. It's a good job you're doing, is excellent, but we can do better by working in a team. Thank you very much.
Thank you, Dr. Mlawa. Ms. Nancy?
In terms of postpartum, we would have the patients that had the gestational diabetes, C-section to follow up in 2 weeks. If they have vaginal delivery, they would follow up either 4 weeks to 12 weeks and be tested to make sure that the blood sugar has normalized after the gestational diabetes. And then we teach our mothers healthy lifestyle habits in terms of healthy weight, healthy nutrition, healthy exercise to reduce the risk of contracting type 2 diabetes. Yeah, and breastfeeding definitely, because it really helps the glucose metabolism for the infant and the glucose metabolism for the mother, and reduces risk the whole way around.
Okay, thank you, Ms. Nancy. I know we have nurses here from different hospitals. So just to summarize things that we've seen within your patients, and then what the doctors have been discussing from the physician side and from the pediatrician side. So I'm gonna start with Mr. Katunzi here.
Okay, thank you so much for the very nice. Thank you so much for the very nice presentation. Actually, I should commend you for the discussion and the contribution from various angles. I have like something that I want to cement on. The first thing is about antenatal visits. As we all know that these pregnant mothers, they usually come to antenatal visits, but gestation diabetes has not been given a priority. So many of the mothers, they do come for the routine visits, but our eyes are not kept on look on the gestation parts of view. So you find most of the mothers have been coming, but they never tested for the blood glucose and something like that. So at the end, they end up with those complications like fetal microsomic, some maybe shoulder dystocia in the right. So this is something that we need to work on it. And actually, I had a point on what Dr. Mlawa has been saying, that we need a multidisciplinary team. That once we found the mother who comes for the antenatal visits, I know we do some baseline investigations as we know in our settings, but when we found somebody is having something that is better to include maybe the gynecologist, the nutritionist, to speak much on how we can help this mother to avoid the complications. But another issue, which is the issue of the oral drugs. Actually, I can share the experience in my settings. We do avoid the use of sulfonylureas, but mostly we recommend the metformin. And I was so happy to hear like the experience from US, from Dr. Mlawa, is the same like what we are doing in my setting. That we do use metformin, but not to that extent. But also it will depend on the gestation age, but also on the blood glucose level of the mother. So this is what we have been using, and as well we do intervene or integrate with insulin, depending on the status of the mother. So I think we need to outweigh and to see, and also I can add on the point that was been recommended by the physician from this MC hospital, that we should try to see if we can investigate and try to make a cause follow-up to our patient to see if maybe the usage of metformin or the usage of insulin, which might be, which among of them is most effective, and from there on we can intervene. Because I know working and dealing with diabetes patients, sometimes you need to have so much skills, you need to integrate knowledge, because you cannot base on the formulas, because the patients do differ depending on what they are suffering from. Unless otherwise, on the nursing point of view, I know that we nursing, we usually extract out the nursing diagnosis based on the patient that we have. So we should make sure that we treat the patient holistically. When I speak holistically, which means we need to consider the patient on various angles. You know, this patient, when they become firstly diagnosed with diabetes, they usually pass through the grieving process. You know, in our normal setting, when somebody is told that you have diabetes, some they might think of this or something else. So we should consider also the psychological part. We need to counsel the patients, and as well we needed to encourage the closeness with these patients. Like we increase the number of antenatal visits. For example, we might be seeing them maybe weekly, or I don't know. But from my setting, I remember we once discovered a mother who had a bad obstetric history, and maybe she had Gestation diabetes, and they never discovered it earlier. So she had lost like 3 pregnancies. And then when we once discovered it, she was brought in our clinic, and then we started the close observation. And finally, we ended up getting the baby, and the baby was doing fine. So we can see now if we try to bring them closer, how we can achieve what we want to get. So I can really add that. Thank you.
Thank you very much, Mr. Kakins. Mr. Wilson from Luganda.
Yes, Dr. Harriet.
Yes. Can you share just a little few sentences with the experience with gestational diabetic moms and on the part of your neonatal side?
Yeah, thank you very much. First of all, I would like to congratulate all participants on what you have presented, especially on a pregnant mother with diabetes, and also for neonates who born with mother with diabetic patients. For our experience, are not far from what I have said. We encourage, for example, a baby who was born with pregnant mother. For the first day, we do give dextrose D10, what we call 10%, while we are continuing with monitoring of the patient. But on the other side, what myself, I would like to comment on the prevention of on the complications that may lead for a patient born with a diabetic mother, for example, in case of blood sugar. I always do encourage antenatal visit. It is very important to encourage mother. Antenatal visit means that should be frequently checked. If a mother found with have diabetic, a proper channel should be followed. As we know, our patient in Tanzania is not properly. You can find, for example, in Mlawa, everything may be found, but you find the other areas they are difficult to catch up. For example, you can find a nurse or maybe a doctor find a mother with diabetic, but if he or she doesn't know about how to manage a diabetic patient, sometimes can be difficult. So, for this way, I always encourage, we do call the on-job training, especially for neonatal care and for pregnant mothers, including for those with diabetic patients. So it's better to make, if is a forum or maybe a team, to encourage people to go in different areas, for example, in health centers and dispensaries, to train health workers on the management of diabetic pregnant mothers or early detection of diabetic pregnant mothers. And this will reduce even the complication once a mother bear a child with that condition. So on-job training is very important for reduction of baby born with diabetic pregnancies and get those complications. That is on my side.
Thank you very much, Mr. Wilson. Yes, definitely addressing those issues antenatally will help alleviate some of the complications that will happen after the delivery. I think Dr. Msambichaka had a question. I'm not sure if it's direct to you or to the other pediatrician in Tanzania. You asked about are all babies getting 10% dextrose, or is there a criteria that needs to be followed to give that 10%?
So
She's asking all the babies who are hypoglycemic.
I would like to say something back. Well, we usually give the 10% to, not to all babies, especially to those babies below 34 weeks of gestation age, because even the mothers are not yet ready to even produce a drop of milk. Therefore, we support them with 10%. Otherwise, we check with the mother first. If she couldn't produce the 10%, we go for the breast. Sorry, we go for the breast milk if the mother could produce the milk. Yeah, therefore it's not for all babies.
Okay. So I think you guys have a great discussion, and I do agree one of the points that it has to be a multidisciplinary approach. Not one discipline will be able to respond to these moms. They need a pregnant woman. So those are the things that we are trying to focus on, try to develop and encourage the global discussion like that, so we can learn from best practice from different locations and then to improve the patient's life. So the more we are involved, the more we are educated ourselves, and then we'll be able to address our patients and take care of them and increase their safety. So if anybody has a question or comment. Oh, yeah.
Yeah, no, I was going to say that the common theme in almost every aspect of business and healthcare is teamwork. What I would recommend for our brothers and sisters here is to look into team formation and capacities initially, if that's something that you want to develop. And then you can have a strong team, because a team does not mean that it's effective. A team with the capacities and the right combination of people is more effective than any individual or organization, because you can have 50 people and you can have a team of 5 people who are more effective at handling a specific area like we're talking about here with diabetes than, let's say, the organization or the institution itself. And it's all in the art of building a team. It's a lot more complicated than sometimes people think it is.
Yes, thank you very much. No other comments? Anybody from over there? Dr. Gideon, Ms. Nancy, Dr. Msambichaka?
No, great discussion, everyone.
Thank you, Dr. Tangi.
I just wanted to comment after such a discussion very quickly. What we have to learn is that we need to have a system effective and efficient.
Yes.
That addresses issues. And health workers, the health provider should understand how to approach maybe screening people.
Yes.
And on the other hand, we know we have a number of people who are not accessing such services.
Yes.
And we still, maybe in the villages and whatever areas where the access or even testing for blood sugar is like going for. So we have issues really to have a system which will address, maybe having some visiting teams to all the other peripheral health facilities, trying to go in and see where we have women pre-pregnancy screen. This is very important. Sometimes women who are pre-diabetic, family history of diabetes, they remain unfertile for some time. And once they get a pregnancy, they just lose. They don't know, no one is screening them because of maybe abortions. And they stay like that in life. So access to services is very important also. And have a team that monitor all this, keep data, and this not level. It should go from the Ministry of Health, probably somewhere to the hospital, to the district, to the regional, until it reaches somewhere there. And that's through health system. That will address the whole issue of package of system. Otherwise, the success for individual institutional work is very little. We need to team up.
No, thank you very much, Dr. Tangan. Yeah, definitely multidisciplinary is needed.
Okay, I thank everybody for coming here and spend time with us. And definitely we have to do this more often, as Dr. Kitange said, coming together and then discussing, that will help and we can learn from each other. So that's what we're intending to do. So next time when you see my invitation, please come. We need your opinion, we need your expertise. So the only way we can move forward is to improve and learn from each other, from best practice. So this was a very positive meeting. So I thank everybody else and thank you and good luck for your work today.
Thank you.
Thank you so much.
Bye.
Thank you. Bye.
Thanks for coming. I'm gonna come and find you. Yeah.
And I'm very excited to be with all of you today.